Hello friends, today we will talk about the problem of plenty. Last 3 days, we heard Dr. Meghna A. Nayak, who was speaking what to do when the couple have no issues. Now here, today I'm talking, maybe I will be talking tomorrow as well about this because it's a huge topic, monochorionic twins, diagnosis and management. Here is the problem of plenty. Twins in general, there are all possible complications. I jokingly tell my undergraduate students that when you don't know what to answer, just think of all the chapters in obstetrics and you will be correct to your shock and surprise. But there are two problems that cannot be there in twins. One is post-term, very, very rare. I have never heard any twin going post-term. And second is macrosomia, by its definition, that is more than 3.5 kg. One baby may be bigger than the other, but it will never be macrosomia. Apart from that, you name a complication in obstetrics that will be there in twins. I also tell jokingly that's the easiest question on earth, the complications of twins. But the most serious risk is that of preterm labor and the higher rates of anomalies and fetal growth restrictions. But monochorionic twins have unique complications. They form a big chunk of the twin topic. What are those unique complications in monochorionic twins? The most famous or notorious twin-to-twin transfusion syndrome, shortly called TTTS. The next one is twin anemia polycythemia syndrome, TAPS, which is like a poor man's version of TTTS or a sibling of TTTS. Then there is twin reversed arterial perfusion sequence, what we call TRAP, selective FGR, and single fetal demise. These are the unique complications of monochorionic twins and increase the risk of, they all increase the risk of neurologic morbidity and perinatal mortality. So we need to understand each one of them, we need to diagnose them, and we need to treat them. This can be a very long question in the MS examination, or each one of them can come as a short note. And in practicing situation, we will come across them and we will have to diagnose them and probably refer them to a higher center where fetal medicine facilities are available. How do you determine the chorionicity? This is the commonest question that is asked. Earlier, we used to bother much about zygosity. Yes, it is important, but during pregnancy, chorionicity is much more important. Zygosity probably is important. Once the children are born, you would like to know whether they are identical, non-identical, and so on and so forth. But during pregnancy, we have to determine the chorionicity, and the best way is by looking at the placenta, whether there is single placenta or two placenta. Presence or absence of the inter-twin membranes. How many membranes are there? 2 or 4. And their sonographic characteristics, thick, thin, shape, T-shaped, lambda-shaped, etc. The best time to determine the chorionicity is first trimester, but after 7 weeks, the sensitivity is equal to or more than 98%. The early second trimester is not bad, but the sensitivity drops to 90%. And thereafter, it becomes more difficult as the babies become bigger and bigger, the cavities become also bigger and the intertwin membranes become thinner, and it becomes that much more difficult. The assessment of fetal membranes is more difficult and less accurate in the third trimester, obviously. Now, dichorionic twins will have two separate placentae. That's very clear, as the name suggests. There will be what is called twin peak or lambda sign, gamma sign. Can you see here? The gamma sign. That is a chorionic plate which runs between the two amniotic cavities, giving rise to what is called twin peak sign, something like a peak. It goes like that. It is best seen between 10 and 14 weeks. It is less prominent after 20 weeks, obviously because of the compression by the growing amniotic cavities. There will be thicker intertwin membranes later. The lambda sign may disappear, but still the intertwin membranes may be thicker because there will be 4 layers, the 2 amnion and the 2 chorions. It consists of 2 layers, as I said, 2 layers of both amnion and chorion. Whereas monochorionic twin, the intertwin membrane will have the shape of T. As you can see here, there will be just like a T, that is one line coming like that, and that is the transverse limb of the T. Thin with 2 layers of amnion only. The chorion plates won't be there in between. No consensus about the cutoff between thin and thick membranes. Roughly, the threshold of 1.5 to 2 millimeters in first trimester is suggested, the intertwin thickness. But it's very difficult to make out this 1.5 to 2 millimeters unless you have a high resolution ultrasound. Thickness is less obvious later in pregnancy, obviously. Now, all monochorionic are monozygotic to start with. As you can see here, depending upon the time of split, they can be of different types though. They start with single zygote, agreed. If the zygote decides to split within first 4 days before the chorionic plate is formed, then for all practical purposes, they will behave like 2 zygotes. Each one will develop its own chorion. So that's why there'll be dichorionic, diamniotic twins. Those started with single zygote. Whereas if the division occurs after the formation of chorionic plate, that is by around 4th day it is formed, 4th to 8th day it decides to split. Obviously, there will be single chorion, that is monochorionic, but 2 amniotic cavities, as you can see in the second picture. So monochorionic, diamniotic twins. If the division occurs after the formation of amniotic cavity, that is between 8 and 12 days, you will have monochorionic and monoamniotic twins. What if the zygote decides to split after 13 days? Then obviously you will have conjoined twins because already there is formation of the babies. So after 13 days, 13 is bad number for many people. So it is like conjoined twins is not really a welcome thing. After 13 days, it will be conjoined twins. I hope it's all very clear. Only 20% of dichorionic are monozygotic in origin. All others are dizygotic. See, if you see single chorion and 2 amniotic, there is no problem at all. But when you see 2 placentae, 2 chorion, you don't know whether it is to start with dizygotic or monozygotic, because as I just explained, the monozygotic can also have dichorionic, but it is only 20%. 80% are because of dizygotic. Now let us look at why it is so important. This particular recent article published in 2020, where 6,225 cases were studied. It's very clear. Chorioamnionicity. Dichorionic were 4,896, monochorionic diamniotic were 1,274, and monochorionic and monoamniotic were 55 patients. Let us see what are the problems with all of them. Pregnancy loss before 24 weeks, obviously high in monochorionic monoamniotic, 21.8%. Very less in dichorionic, because each one of them will have their own placenta and they will take care of themselves. Whereas in MCDA, they will fight maybe and both of them will lose before 24 weeks. Fetal or neonatal death after 24 weeks, again very high in case of monochorionic and monoamniotic, 9.3%, least in dichorionic and diamniotic. Birth between 24 and 32 weeks with at least one live birth. Okay, so again, the situation is better in case of dichorionic, whereas in monochorionic monoamniotic, most of them would deliver between 24 and 32 weeks. Birth between 32 and 34, who can go up till there, weeks with at least one live birth. As you can see here, it is again better in dichorionic. It is not so good in monochorionic. Small for gestational age. As you can see here, monochorionic diamniotic, there will be fight for the supply. So it is more there, 37.8%. 10% of these underwent actually fetoscopic laser ablation for twin-to-twin transfusion syndrome or selective growth restriction. Outcome data would have been poorer without this intervention in monochorionic diamniotic. This is the asterisk I am explaining here. Now let us take up one by one complications. The first one, the major one, is twin-to-twin transfusion syndrome, that is called TTTS. I have highlighted that in red color. It is because of unbalanced blood flow in anastomotic vessels along the equatorial plate of the shared placenta. As you know, in monochorionic type of twins, the placenta is shared. When it is shared, there will be anastomosis between the vessels, artery to vein, vein to vein, artery to artery, all sorts of things. But the problem is the blood flow is unbalanced. If it is the single type of vessel, artery to artery, it will be usually balanced. Whereas if it is artery to vein, it is not balanced. One is bigger, other one is smaller, maybe, or there will be elasticity in arteries, whereas not so much of elasticity in veins. And it's something like smaller pipe is connected to the bigger pipe. When from the bigger pipe, the water rushes into the smaller pipe, the pressure is more. Or when it goes vice versa, the pressure is less. So it is unbalanced blood flow, which is very important. Remember this word, unbalanced. It is characterized by relative hypovolemia in one twin and hypervolemia in the other. So there is, as the name suggests, one twin is transfusing into another. So there will be hypovolemia in the donor, hypervolemia in the recipient. So in other words, in terms of obstetrics, we can say oligohydramnias, where maximum vertical pocket, MVP is also Muralidhar V5, but it is here maximum vertical pocket less than 2 centimeters. Or it could be anhydramnias also in one amniotic sac. Whereas polyhydramnias in the other one where MVP is more than 8 centimeters. So it's usually called oligopoly sequence in short and in stylish way. 9 to 15% of monochorionic diamniotic twins and 6% of monochorionic monoamniotic twins can have TTTS. It's obviously more in monochorionic and diamniotic twins. 9 to 15%. What is the pathophysiology? I have already told you about this unbalanced blood flow. There are three types of vascular connections that are possible. Number one, arterio-arterial. What do you think? That's the best actually. Arterio to arterio. It's almost like same lumen and same way. The second one is arteriovenous. They are obviously not the good ones. Then there is veno-venous. The three major factors in the pathogenesis are, number one, lack of arterio-arterio anastomosis. As I just now told you, arterio-arterio is the best. If that is there, the blood flow is sort of balanced. So if there is lack of arterio-arterio anastomosis, the blood flow across the twins will be unbalanced, and that is the problem. Second one is unbalanced arteriovenous anastomosis, implanting. And third one is release of vasoactive mediators. When these transfusions are going on between them, there will be a release of vasoactive mediators, and they also will play a role in TTTS. Let us look at that. The lack of arterio-arterial anastomosis, how does it act? Are thought to be protective. Arterio-arterial anastomosis are thought to be protective against development of TTTS by correcting inter-twin volume imbalance caused by the unbalanced arteriovenous anastomosis. I have already explained that many times, so there is no need to explain again. Whereas in unbalanced arteriovenous anastomosis, there is uncompensated hydrostatic and osmotic forces will lead to net transfer of fluid from one twin to the another. So wherever is the bigger one, they will drain into the smaller one. So that is the problem when there is arteriovenous anastomosis. It will be unbalanced flow. Then the third one is release of vasoactive mediators. There is activation of renin-angiotensin-aldosterone system, what we call RAS, and there is release of angiotensin 2, renin, aldosterone, as well as vasopressin in the donor twin to restore its vascular volume and maintain BP. So when the donor is losing out on the fluid, in order to compensate, there will be release of angiotensin 2, renin, aldosterone, and vasopressin. As a result, what happens? There will be oliguria, anhydramnios, and the stuck twin phenotype in severe cases. So that's how vasoactive mediators also play a major role. Other set of vasoactive mediators are, there will be chronic hypovolemia in the recipient. We saw what happens in the donor. In donor, renin, aldosterone, vasopressin, all these are produced. Whereas in the recipient twin, it causes cardiac atria to stretch because it is receiving lot of blood, lot of fluid. So it will stretch, and there is release of atrial natriuretic peptide. Ventricular stretch results in release of brain natriuretic peptide. What happens as a result? These hormones promote vasodilatation, natriuresis, and inhibition of the RAS, leading to polyuria and polyhydramnios. See, this is the funniest part. The donor is actually losing, but without its knowledge, to compensate for the further loss, it produces all those vasoactive mediators which will worsen the situation for itself. Whereas the recipient is receiving lot of things, lot of blood, lot of volume, lot of fluid. So in order to get rid of that, it will produce such vasoactive mediators which will ultimately cause vasodilatation and polyuria and polyhydramnios. So that will also worsen the situation. So the recipient will keep on worsening. The donor also keep on worsening. That's how there will be oligohydramnios in one, polyhydramnios in the other. Over time, however, the recipient can develop hypertensive cardiomyopathy. No other way, no other go. So there is something called intrapartum TTTS. What I just now explained is the antepartum or prenatal TTTS. Suddenly in the labor also there can be TTTS. It could be on the chronic TTTS or acute over chronic, as well as first time occurring in the labor also. Acute intrapartum TTTS occur when delivery from a rapid and large intertwin blood transfusion from the donor to the recipient. So this will be a very large amount suddenly happening in the labor. This leads to acute anemia and possibly hypovolemic shock in the donor and acute polycythemia in the recipient twin. The incidence is fortunately less, 1.5 to 2.5% only of all MCDA twins, irrespective of mode of delivery. Now, why this is important, irrespective of mode of delivery? Because many people think the moment there is TTTS during antenatal period, we have to go into a cesarean section. No. This intrapartum TTTS is not because of that. Whether the delivery is normal, that is vaginal, or abdominal delivery, this can still happen. That's why this particular last clause, irrespective of mode of delivery, is very important, and I have underlined that. And it is less. How do you diagnose TTTS? Of course, there is single placenta with twin, and there will be oligo polyhydramnios sequence, oligopoly sequence. Oligo means MVP less than 2 centimeter. Poly means it is usually more than 8 centimeters, but there is further division. In the earlier gestation, it may not be 8, it is just 6 centimeters, 15 to 17 weeks. 18 to 20 weeks, it will be 8 centimeters. And more than 20 weeks, it is 10 centimeters and more. That's how you diagnose TTTS. Then, as I said, towards the end, once the things worsen, there will be stuck twin appearance. Are genetic studies needed for TTTS? Yes, TTTS is a problem, but is it due to genetic reasons? TTTS is not associated with increased risk for chromosomal abnormalities or genetic syndromes. It is purely mechanical. It is because of the anastomosis between the artery and the veins, which will lead to unbalanced transfusion. It has nothing to do with the genetics. Many people, many postgraduates do not understand this. So fetal genetic studies are not offered unless there is another reason for these studies. In twins, as such, the anomalies are more, congenital anomalies are more, that's another issue. There you may ask for genetic studies, but just because the lady has TTTS, don't have to ask for genetic studies. How do you predict? Can we predict this? Yes. First trimester nuchal translucency more than 95th percentile in one or both the fetuses. This is a case for TTTS. Crown rump length discordance more than 10% in the first trimester. This is a predictor of TTTS. So what are the maternal problems with TTTS? Mother is usually asymptomatic unless the hydramnios, polyhydramnios is so much to give her mechanical pressure. Otherwise, she is asymptomatic. It's a fight between the two babies inside. But symptoms related to excessive uterine distension, as just now I said, may occur, including discomfort while lying supine, or there can be insomnia, early satiety, lower abdominal pain, orthopnea, and pelvic pressure. There is something called mirror syndrome, that is generalized maternal edema, usually associated with hypertension, which has been reported in cases with a hydropic fetus. If the problem is there inside the uterus, that will be mirrored in the mother as well in terms of edema all over the body. There is premature cervical shortening. Please recall my talk on cervical insufficiency. Here it is purely mechanical reasons. That is, the intrauterine volume is increased, and that will exert pressure on a cervix which otherwise can hold the pregnancy. But when extra pressure is given on the cervix, this cannot hold the pregnancy. It has nothing to do with the contractions. If you recall, the definition of cervical insufficiency, it is in the absence of uterine contractions. It is purely mechanical pressure. Cervical cerclage did not prolong the pregnancy or improve perinatal survival because the intrauterine pressure is going to increase by the day. So if you put a stitch, okay, it may hold on for some time, but as the pregnancy advances, it will put further pressure and the stitch may come off. So consider use of either pessary or progesterone 200 milligrams vaginally. This is again some sort of a desperate attempt to hold on with the pregnancy, but it may not help much. Progesterone will help only if the distension of the uterus is causing contractions, and pessary as such, the randomized control studies have not shown to be very effective. How do you monitor the cases of TTTS? TAPS and selective FGR, the monitoring is same. So I don't want to repeat it again when I talk about TAPS and SFGR. Please recall this slide. Serial fetal ultrasound examinations are necessary. This is very, very, very important. And consultation and co-management with maternal fetal medicine. Nowadays, most of the hospitals are developing maternal fetal medicine, and whenever it is there in your hospital, you must consult with them and you have to co-manage with them. The screening protocol for monitoring will be something like this: 11 to 14 weeks, assessment of gestational age, estimated date of delivery, assessment of chorionicity, and measurement of nuchal translucency. This is somewhat routine. Now, between 16 and 18 weeks, you have to measure the fetal size, early fetal anatomic survey, including presence and size of fetal bladder. That bladder is very important when I talk about quinteros staging, maybe tomorrow. And maximum vertical pocket of amniotic fluid should be assessed. Doppler measurements of MCA PSV, Doppler measurements of end diastolic velocity of the uterine or umbilical artery, assessment of placental discordancy echogenicity, which is called PDE. When it is 20 weeks and above, fetal size, detailed fetal anatomic survey, MVP, echocardiogram, Doppler measurements of MCA PSV, and umbilical artery endostolic velocity will continue, and PDE. And 20 to 22 weeks, you have to start measuring the cervical length because now there will be pressure on the cervix. 22 to 32 weeks, you have to do serial examination of fetal growth every 4 weeks, and serial examination following 2 weeks, you have to do MVP, size of fetal bladder, Doppler measurements of MCA